So I'm going to come from this, I'm going to ask some questions away. I'm not sure if I missed the first bit. In terms of what you were asking questions in terms of what organs you would accept. I can't comment on renal transplants right now, but I'm going to ask you just put your hands up. You're waiting for a liver transplant. You're offered a liver donor. You're told that a liver donor has hepatitis B. Hands up who would accept that organ. There's about 50, no, actually majority no, it's the clinicians who are saying yes. Your hepatitis C infected donor, and you're waiting for a liver, would you accept that organ? Interesting, yeah, okay, so there's a far fewer, it's certainly in my knowledge.
Depends on whether we've been told we're going to die in a week or a year.
Give me a chance. Okay. This is from NHSBT. Anyone from NHSBT here? All right. So this is from your website. I've got my own view on this. A big advert for the increase in donation in the UK. We're still way behind many European countries, woefully behind European countries. I think this is a target, and I just wonder about how much of this was target hitting. I'm going to be a bit naughty here, because actually whilst there the 50% increase in donation wasn't matched by a 50% increase in transplants carried out. And the problem is that it's all about the liver. It's not like Lance Armstrong would say, so it's not about the bike, but actually in this case, it's all about the liver. So you're absolutely right. It's about the quality of the organ that is being offered up to you and your clinical need at that time. So any discussions about actually any organ has to be put in that context. And indeed, in the UK transplantation, certainly for livers, we are moving much more to a severity of illness model. And what's going to happen is that patients, and if we go through a national listing program, you'll have patients who have the severest disease, i.e. the most advanced liver disease, will be effectively offered a first choice of livers. And this is going to raise some difficult questions, because on the one hand, those are the patients who are the sickest. And so therefore those are the patients who need really the very best quality organ for them to get through that ITU phase, etc., etc. However, if the only organs they're being offered are from very fatty livers, from poor quality livers, from non-heart-beating donors, which patients struggle with sometimes, and actually the big increase is actually from the non-heart-beating donors, you can see that we're going to have an increase in transplant mortality related to transplantation, and a big and already documented increase in the cost of transplantation, because instead of people, even very sick people, going onto ITU, ventilated for a night, and sometimes not even a night, coming off ITU the next day, you've got patients staying in ITU, they get this not very good graft, and they sit in ITU for 5, 6, 10, 15 days, because the organ takes a while to work. And so that is the context that I'm putting these discussions in. Are there any questions on what I've just said? Everyone understands that. So it's very important that you understand that picture, and then we can actually talk about the organs themselves. There we go. It is about the liver. It's all about the liver. And actually, work from both here, work from King's, work from Birmingham, all identified that DC donors, these are patients whose hearts have actually stopped, patients with fatty livers, poor quality organs, they're staying in ITU a lot longer. So this is exposing a patient to a risk. And interestingly, actually, do we as transplant physicians say, go up to the patient and say, this is a fatty donor, do you want to take it? Well, we don't, because we take, this is a patient who's very high risk, advanced liver disease, and that's the best we've got at the moment. And yet we are encouraged to discuss with those patients if that donor has a virus, for instance. Do you wish to take that risk of having a virus? So there is a complexity here, which I don't think we necessarily are addressing. Some of these are going to be, CMV has already been talked about, HIV is going to be talked about. H1N1 I'm going to just touch on. HTLV1, we don't exclude patients, but some we do get, the patients are screened, or the donors sometimes are screened for that, but I'm not going to touch on that anymore. I arrived here 92, and I think sort of 92, 93, lamivudine arrived. And I remember when I was on the unit, we were one of the first hospitals to have access to lamivudine. And so what happened was that hepatitis B recipients, so those are patients who've got hepatitis B related cirrhosis, who previously were off the list. Okay, so they had, because they got this a very aggressive hepatitis B, they got cholestatic hepatitis, and they were dead within a year or 2 years, most of that time in hospital and yellow and not feeling well. Lamivudine stopped hepatitis B replication, and it meant that these patients could be transplanted. So a real game changer of a drug, extraordinary drug, brilliant design to actually introduce this agent. So I've just talked about the recipients at that point. So we were able to start to transplant recipients, and they got hepatitis B, lamivudine resistance. But then pharmacists, very clever, they came up with new drugs. So we then had adefovir, we've now got tenofovir, we've got entecavir. These are very, very effective drugs. So hepatitis B patients are being transplanted, and they are not getting hepatitis B back. So let's look at the donors. So if you transplant a hepatitis B surface antigen positive donor into a patient, that patient will the donor will usually have an element of circulating virus, and you run the risk of introducing hepatitis B into that donor. And so for a long time, those organs were not being accepted, because the worry was you were going to introduce hepatitis B into the recipient. Clear on that? So, hepatitis B surface antigen is no longer a contraindication. Why? Because we can give them these drugs. These drugs are highly, highly effective. So it's all about the liver. If it was me on the waiting list, and if I was either very sick or actually not that sick, I would happily personally take a good quality graft from somebody who's hepatitis B surface antigen positive, because I know that it's likely I will tolerate tenofovir or entecavir. These are very well tolerated drugs. So it's all about the liver. I would much rather have a good quality hepatitis B surface antigen liver than a fatty liver. We're expanding the pool. Now, hepatitis C antibody donors. Now, the current policy is if the donor is hepatitis C antibody positive, we would only consider that organ for patients who have got hepatitis C. So the idea is you're putting the hepatitis virus into somebody who's already got the hepatitis virus. Now, don't forget, however, that if you expose a population, 100 people, to hepatitis C, 20% of them at least will clear the virus on their own. So 20% of those donors, and in some studies it's up to 30, 40, 50% of those donors, will actually be PCR negative. They will have cleared their virus. But we don't take the risk of using these. We can't get a PCR in time, and we don't take the risk of putting in patients who've not got hepatitis C, because up until now, hepatitis C recurrence in the graft causes graft loss. It is a problem. But again, we're repeating hepatitis B here, because you've got this new sort of smorgasbord, shall we say, of antiviral therapies which are imminently to be licensed in the end of this year and the end of 2014 and 15, and these are likely to result in clearance of the virus. So I think in the next 2 years we will not just be using hepatitis C donors for patients who are hepatitis C positive, but also if it's a good quality graft. Again, if it was me and I'm poorly, I'm waiting on the lift, it's list, it's all about the liver, and I would take that organ. I don't think anyone's talking about H1N1, but are they? No. So actually, it's good. Douglas, I did my research anyway. So when the H1N1 outbreak occurred, patients were dying on ITU, and the question was, could we use those organs? And they were, sadly, sometimes young people, and therefore good quality organs, and needed to be considered. And generous people donated. So Doug and colleagues had a day, and that was published in Transplantation. They looked at 13 organs taken from 5 known H1N1 donors, and none of the recipients developed H1N1. And actually the screening, and they comment, the screening and the prophylaxis was pretty variable throughout the units. There wasn't a hard and fast approach to that group of patients. So most of us think there'll be another of these pandemics around the corner, and that just gives us at least some evidence to base our approach with these patients. I'm not going to talk about that. That's all I'm going to say, because the important thing is that viral hepatitis, the pharmacological dynamic has been truly extraordinary. And you are seeing this same in hepatitis C as we have seen in hepatitis B. And essentially it is opening up that organ pool. Okay, thank you.